have you ever found yourself scratching your head over hypercalcemia? You are not alone. By the end of this video, you are going to be confidently working through those differentials of hypercalcemia like it ain't no thing, including the pesky endocrinology ones like hyperparathyroidism and familial hypocalciuric hypercalcemia. Yes, we're going there. You and me. Hello Dr. Humans, welcome back to the channel. My name is Kristeen and today we're gonna unpack a step-by-step approach to hypercalcemia so that it finally makes sense and you never forget. So without further ado, let's jump into today's clinical scenario. Here you have a 55-year-old woman who's referred after routine bloods showed an elevated calcium. She's well, she has no past medical history, she denies any recent immobilization, vitamin D supplementation, or the use of thiazide diuretics. Her investigations are shown here. Which of the following is the most likely diagnosis? And the options are FHH, tertiary hyperparathyroidism, primary hyperparathyroidism, malignancy-related hypercalcemia, or sarcoidosis. What's it gonna be? Now, I want you to screenshot this question, place it on a Word document, and commit to your answer. Then, I want you to keep watching so that we can unpack this together and make some notes along the way. And if you are looking for more practice MCQs for your exams, as well as the best place to learn renal medicine on the internet, then be sure to check out the Renal for the Written programme over on our website. When you sign up, you'll get instant access to the entire on-demand programme, and you'll also get to hang out with me at the live whiteboard events. Be sure to check that out and I'll leave a link to that below. But now let's get back to hypercalcemia. So when you have a patient with hypercalcemia, categorize it into PTH-dependent and PTH-independent. So basically we're going to send off a PTH level and figure out if it's suppressed or not suppressed. And just to make sure that we're all on the same page, let's quickly revise the relationship between PTH and calcium. So it goes without saying that calcium is a very important ion in the body for the heart, the brain, muscle contraction, blood clotting, so many things. And so in that sense, it's not a surprise that Mother Nature installed an entire gland dedicated to maintaining your calcium homeostasis. And that gland is the parathyroid gland, which is a combination of 4 little glands located just under the thyroid. The parathyroid gland monitors the serum calcium, and when this is low, it releases PTH. And PTH corrects low calcium in a number of ways. In the kidney, PTH promotes vitamin D activation. This activated vitamin D goes to the gut and promotes uptake of calcium from the diet. But we don't want to be relying on our next meal for our entire calcium homeostasis. So PTH does something else. PTH has the ability to march straight up to bone and demand the calcium from the bone. It just takes the calcium from the bone and chucks it into the bloodstream. Problem solved. And as an added bonus, it also promotes the placement of calcium channels, TRPV5, in the distal nephron so that we can absorb more calcium there too. So PTH increases our serum calcium and activated vitamin D levels. And both of these things then provide negative feedback on PTH, and homeostasis is achieved. So coming back to hypercalcemia, when calcium is high, it should be providing negative feedback on PTH. And if that's not the case, then it suggests that there's a problem with this here hormonal axis and PTH is not listening to the calcium, right? It's gone rogue. It's doing its own thing. So we divide the causes of hypercalcemia into PTH-independent, where the PTH is suppressed, and PTH-dependent, where PTH is not suppressed and maybe elevated. So now we're just going to whip through some of the causes of hypercalcemia in these 2 categories. And if you want to make this more interactive and test yourself, then you can pause this video now, brainstorm your own list before hitting play and getting my list. Choose your own adventure. Okay, so when the PTH is suppressed, we have malignant causes and non-malignant causes. Malignant causes include PTH-related protein, which is released from cancer cells as a paraneoplastic phenomenon, osteolytic, so bone breakdown due to bone mets from solid organ cancers, or myeloma, which classically causes lytic lesions of the bone and hypercalcemia. In terms of those non-malignant causes, these include vitamin D or calcium excess, thiazide diuretics, and we have a whole other video on the mechanism of thiazides and hypercalcemia, which I'll link at the end. Granulomatosis disorders like sarcoidosis and tuberculosis can also do this. And the reason for this is because granulomas are just collections of macrophages, and macrophages contain the enzyme 1-alpha hydroxylase, which is the enzyme that activates vitamin D. So the immune cells inside these granulomas in these conditions are actually able to generate more active vitamin D, which then goes to the gut and promotes calcium absorption, and that's why we get hypercalcemia. And some other conditions here are thyrotoxicosis, immobilization, and milk alkali syndrome, which comes from ingesting too much calcium as part of antacid medications for gastritis. So those are some things to evaluate when the PTH is suppressed. But in Our Lady, the PTH was not suppressed, so we can come back here and happily exclude malignancy and sarcoidosis from these differentials. But then we're left with these other differentials for when the PTH is not suppressed. We've got primary hyperparathyroidism, tertiary hyperparathyroidism, and familial hypocalciuric hypercalcemia. And so now, to finish off, what I'm going to do is show you how to differentiate between these conditions using the investigations we have here. So first of all, let's tackle primary versus tertiary hyperparathyroidism. Primary hyperparathyroidism is when the parathyroid gland has gone rogue, either due to hyperplasia or an adenoma, and it's secreting PTH irrespective of the serum calcium. It's called primary because the problem starts inside the parathyroid gland itself. And would you believe that this is the most common cause of hypercalcemia overall, right? We as doctors, especially if we work in an inpatient setting, we often think it's malignancy. But in fact, in the outpatient setting, the leading cause is primary hyperparathyroidism. Now, tertiary hyperparathyroidism, on the other hand, is something that I see in my patients, my end-stage renal failure patients, so either dialysis patients or patients who've recently had a transplant. In CKD, phosphate builds up in the blood because the kidneys are having trouble excreting it. That phosphate binds to calcium and lowers the serum calcium, which then stimulates the parathyroid glands to secrete PTH. But because the kidneys are still having issues getting rid of the phosphate, this loop continues, and this loop is called secondary hyperparathyroidism. Now, secondary hyperparathyroidism is not our focus today because in that situation, calcium is usually normal or low. But in tertiary hyperparathyroidism, this happens after years and years of this secondary stimulation of the parathyroids. The parathyroid gland becomes so hyperstimulated that it develops hyperplasia or adenomas. And these then start to secrete PTH autonomously, irrespective of the serum calcium. So in tertiary hyperparathyroidism, calcium is high or high normal, and PTH is elevated as well. So how do we then tell the difference between primary and tertiary hyperparathyroidism? There are two main clues. The first is the GFR. Tertiary hyperparathyroidism only occurs in advanced CKD. So look for a reduced GFR, a dialysis patient, or someone who's just had a kidney transplant. The second clue is phosphate. PTH normally promotes phosphate excretion in the urine, and so in patients with normal kidneys, a high PTH will lead to the serum phosphate being on the low side, and this is what we see in primary hyperparathyroidism. But in my patients, like I said, phosphate secretion is an issue, and so in both secondary and tertiary hyperparathyroidism, you're not going to have a low phosphate, right? It's going to be high or normal. Now, coming back to our case, our patient has a low serum phosphate and a normal GFR. So we can confidently cross out tertiary hyperparathyroidism. That leaves us with primary hyperparathyroidism versus FHH. Now, FHH is easy. It's a genetic condition, and the clue is in the name: familial hypocalciuric hypercalcemia. Low calcium in the urine, high calcium in the blood. The underlying problem here is a mutation that affects the function of the calcium sensing receptor. And this calcium sensing receptor is found in both the parathyroid gland and in the kidney. In the parathyroid gland, the altered receptor sets a higher calcium threshold, so PTH isn't suppressed as it should be at the regular levels of calcium. In the kidney, the altered receptor causes increased calcium reabsorption, meaning more calcium coming back into the blood and less calcium getting into the urine. So in FHH, you see mildly elevated or normal PTH that isn't suppressed because the calcium sensing receptor is a bit wonky and it's letting that PTH roam free, right? It's not able to inhibit it properly. You'll find a serum calcium that is modestly elevated. It's usually not extreme. It's usually been like that for quite some time. The patient is neither up nor down with it and has no symptoms. It's usually a pretty benign elevation. There's often a family history of hypercalcemia that's stable over many years, and there's importantly a low urinary calcium, and a calcium creatinine clearance of less than 0.01 points strongly towards this condition. And whilst FHH is benign, it's important to recognise this condition because we don't want to misdiagnose these patients with something else and have them undergo unnecessary surgery, for example, right? So we need to separate out these conditions, and how do we do that? How do we separate FHH from primary hyperparathyroidism? And the key here is in that urine calcium test. Like we said, FHH has a low urinary calcium, and a calcium creatinine clearance of less than 0.01 would strongly point towards this. In primary hyperparathyroidism, there will be a normal or even a high urinary calcium, right? When you have high calcium in the blood, what's normal is that there'll be a lot of calcium in the urine, right? We need to get rid of the surplus. So you're going to see a calcium creatinine clearance of greater than 0.02 usually in this condition. And if we're in the grey zone, somewhere between 0.01 and 0.02, genetic testing may be required to delineate between these, but in your exam questions, you'll usually be given pretty clear-cut values. So coming back to our MCQ, this patient has a high urinary calcium, right? It's not low. So FHH is confidently excluded, and that leaves us to arrive at primary hyperparathyroidism as the answer. And like I said, this is the #1 cause of hypercalcemia across the board. So that was the workup of hypercalcemia. I hope this makes sense and it helped your studies. And if you do want to go deeper, check out the Renal for the Written program. I'll leave a link to that below. And if you're curious about other mechanisms, you might want to watch my video on thiazide-induced hypercalcemia right here. Thank you so much for joining me today, and I'll see you again soon for some more high yield learning. Bye!